Just explain a little bit more about the layers and how we've come to understand the hip through this process. This is originally work in the idea and concept of Brian Kelly at HSS and Pete Dravich, who I worked with both of them at Pitt a long time ago. But the concept of trying to understand each of the layers, the osseous meaning the bone, and this is the proximal end of the femur, and it's round and it fits into a cup called the acetabulum, and the acetabulum is a part of the pelvis. And this is the longest lever with the shortest lever arm in the human body, and it has the most force generated by it if it gets caught prematurely. As long as it moves normally, everything's fine, but if it gets caught, then it's like it will generate a lot of abnormal force. So, and then these abnormal forces are generated through the pelvis, and that's what leads to the complexity, is the body trying to control this force. So it does it through the labrum, which is a little ring valve that sits here. It's layer 2. And then there's a capsule that goes around, and it's composed of ligaments that are here in the front of the hip. There's first, the biggest is that runs on the front of the hip is the iliofemoral ligament, and has a medial arm and a lateral arm. It used to be called the Y ligament of Bigelow. And then the pubofem. The pubofem wraps around from the medial part and wraps around the bottom part of the hip socket in this fashion. And then you have a really big one called the ischiofemoral ligament that wraps around from the back, that goes across the top, and it actually inserts on the greater trochanter. So these all have distinct functions. They're generally just called the capsule, but I'll have you know that they have distinct function, and we spent a lot of time working on that in the anatomy lab. And then there's the ligament teres that sits in the center, and it has a function in flexion. All of these ligaments mostly dominantly work in extension whenever the hip is extended to control these big forces. Whenever the hip is flexed up, the ligaments mostly relax, except for the teres and the pubofem, which are on the bottom, and they help to control the stability of the hip, which is a different problem. So it goes from stability, with an extension and all the ligaments working hard and tight, to being relaxed and loose packed when they're flexed, and primarily the pubofemoral ligament working to cradle the femoral head along with the secondary, or primarily the ligament teres. So that's what helps to control the function in flexion. So that's how the ligaments work. Now let's talk about the muscles and tendons. So the big ones that we need to be aware of at layer 3 is we need to be aware of the arbitrator internus, because it goes in and inserts on the back part of the hip, and it's faucet just below the piriformis. And so we have the piriformis and the arbitrator internus, and they go to the back side of the hip. So when the hip moves, it's pulling things on the pelvis, the inside of the pelvis. You can't take a step without that happening. And the other one on the front side is the psoas, and the psoas comes here. You guys are used to that in all your interpelvic work, but as it comes across into this here, it comes into our world, it inserts on the lesser trochanter. And so if that gets tight and you have a positive hip flexion contracture, it starts to pull in the nerves that cross through the psoas, and then you have layer 4. So starting with the nerves that can get entrapped on the front, iliohypogastric, iliolumbar, they can all be in approximation. They can get scarred down into the psoas, and they can have some secondary strain. Then you get into secondary strain parameters on the rectus abdominis anteriorly, or ilioinguinal even. So they can be affected by cascading pathology anteriorly. Posteriorly, the main ones that we're talking about are the piriformis, and that would be the sciatic, and you have a penetrating branch of S2 on a certain number, and that can also get squeezed posteriorly, or the arbitrator internus, which is primarily and dominantly associated with the pudendal inferiorly, and that would go along the inner aspect. So that would be layer 3's cascade. The layer 4 being the nerves that are being caught by the muscle. But where did it start? Well, it started usually in the hip and from the bone and cascades that way, but it doesn't mean that if you have a sagittal plane balance from improper tone of your abdomen, or you have a restriction from an injury or weakness in your hip muscles, that you can induce a layer 3 can induce a layer 1 problem. And from that, the proper treatment is always for education and just proper physical therapy. So, and then layer 5 Layer 5 really is the kinematic chain, meaning the lumbar spine and the length. The SI joint can also be involved, or it can be the transfer load of strain. So if the hip can't extend, it's going to transfer the load from here by hitting prematurely and transferring the load to the lumbar spine. And that can cause a lot of problems. So also physical therapy to accommodate the pathologies are the first step, strengthens the second, and then if you can't, then we have to have further evaluation. So that's layer 5, and then the layer 6 has been brought to my attention is that sometimes these pathologies are so complex and they go on for so long that the patients can become frustrated and it can lead to depression. I've seen the most terrible things with unrecognized pathology for a long time. So hopefully by sorting this out in a very structured examination and recognizing the interrelationship, then we can help patients get to a base diagnosis of each layer earlier and sooner. So I hope that helps.